Hello, my name is Chelsea O'Malley, and this is the video case presentation for ReelDx case 408. This patient is a 48-year-old obese female with a history of chronic heart failure, coronary artery disease, hypertension, diabetes type 2, and MRSA infection, who is presenting to clinic with a chief complaint of worsening body swelling and shortness of breath that's been going on for 1 week. She reports that the swelling began in her legs and has spread to her upper extremities and her chest area. She also has widespread pain throughout her body and is complaining of chest pain that is rated an 8 out of 10. Her primary doctor recently increased her furosemide to 80 milligrams BID and has provided limited relief for her symptoms. Pertinent social history for this patient. She is impoverished, lives in a trailer. She has poor hygiene upon presentation. Pertinent physical exam findings are that she has diffuse 3+ edema in her lower extremities all the way up to her abdomen, chest, and breasts. She appears to have open MRSA sores all over her body that have various stages of healing. Her lungs are clear on auscultation. She is hypertensive on exam with a blood pressure of 184/94. With these findings and history, my differential diagnoses include acute heart failure exacerbation based on diffuse edema throughout her body and her shortness of breath that's been worsening. The next differential would be myocardial infarction based upon her chest pain and her history of coronary artery disease. Lastly, and least likely differential would be a pulmonary embolus based off of the chest pain that she has and the shortness of breath. And her risk factor of being obese. So most likely, my impression and diagnosis for this patient is that she is having an ischemic heart failure exacerbation, given the widespread worsening edema and shortness of breath, and her history of coronary artery disease and her uncontrolled hypertension today. So for this patient's problem list and plan, for her acute heart failure exacerbation, the first goal is to give her some euvolemia. So I would plan to administer IV diuretics either in the clinic or admit her to an inpatient setting. I would encourage that she receive bumetanide since it's more bioavailable in an IV push form. I would order an EKG, an echocardiogram, and a chest X-ray to better ascertain the ejection fraction, the heart rhythm and rate, and the cardiopulmonary size. I would order a troponin level to rule out myocardial infarction. I would order a D-dimer to rule out PE. I would also order a comprehensive metabolic panel, a B-natriuretic peptide to assess her end organ function and her cardiac stretch. Once she is euvolemic, I would plan to titrate her guideline-directed medical therapy according to the most recent guidelines, such as the lisinopril and carvedilol that she has listed on her medications, to appropriate doses as tolerated. This patient needs heart failure education, such as low-sodium diet, weight monitoring and control, and fluid restriction of 2 liters per day to prevent reexacerbation. She will need serial lab monitoring with a basic metabolic panel once weekly while titrating her guideline-directed medical therapy to assess for kidney injury. She should be seen in either a heart failure clinic or primary clinic in 1 month for follow-up to assess her fluid status. She will also need another echocardiogram in 6 months after this current exacerbation to assess her cardiac function. Next, for this patient's hypertension, the plan is to titrate the guideline-directed medical therapy to help lower her blood pressure. We would want it titrated to a goal blood pressure of less than 130/90 as tolerated over time. She would be encouraged to engage in blood pressure control, monitoring at home in addition to home weights. For this patient's diabetes, I would draw a hemoglobin A1C to better assess her current dosing. The case says she's on metformin, so I would assess this dose according to the hemoglobin A1C and adjust this dose if appropriate, and perhaps add insulin later on if needed. I would consider ordering referrals for a dietitian and for an endocrinologist to help her better control her her blood sugars at home and to give her a better idea on how she could improve her diet. She also needs an appropriate exercise regimen. 30 minutes, 3 to 4 times a week would be appropriate for her to start, perhaps low impact walking to start and increasing as tolerated to help control her weight as well as her blood pressures. For this patient's MRSA infection, given that she has several open sores on her body, I would first order her an urgent referral to infectious disease to give her better wound care and control. I would consult a wound care nurse to make sure that these wounds aren't getting worse and that she has appropriate care. The case says that she's on doxycycline. I would continue this current dose until she's able to see an infectious disease specialist. Next and lastly, I would consult social work for this patient, given her socioeconomic status. I'd like to ensure that she has appropriate resources considering how many comorbidities she has. She would need, considering she's on so many medications, it would be appropriate to make sure that she can get these medications and that they're priced well, considering she may have a low income. So to conclude, this patient's a 45-year-old obese female with a diagnosis of acute heart failure exacerbation. She'll receive IV diuretics today. Afterwards, we will titrate her guideline-directed medical therapy and order serial testing for echocardiograms and lab work to make sure we are not damaging her end organs.